All right, thank you. So I want to have also first Pinar say something since she's the director of the center, and then I'll take it over and give the welcome.
I just want to say welcome. It's really, really wonderful to have all of you here with us today, especially on this very, very cold day, very cold for Atlanta. Although I know some of you lived in other places and maybe you think this is not too bad, but for those of us who lived in Atlanta for a long time, it's probably one of the worst days of the winter, so we are a bit spoiled. But thank you for joining us. We have a very exciting program ahead of us with a panel discussion, presentations, and poster session. Hope you enjoy, make some new connections, meet people that you reconnect with people that maybe you knew before, learn some new things, generate ideas, and hopefully build some new collaborations. So that's what we hope to achieve. But without further ado, I'll turn it back over to my colleague, Dr. Nazal, and looking forward to interacting with all of you during the day. Thank you. Thank you for being here.
Thanks, Pinar. Okay, so thank you very much for joining us again. I'd like to welcome each and every one of you. We're very excited. The microphone. Okay. So I should stand here. Okay. All right. No, that's okay. Thank you. So I'd like to welcome each and every one of you for joining us today. We're very excited to share all of the research work that has been done at Georgia Tech, at Emory, at other places. I want to welcome all of our panelists and our rapid fire presenters. And I want to welcome our students who took time out of this kind of the end of the semester, where I know you're all just trying to keep your head above the water at this point. And without further ado, so let me get started with some first, let's see if the clicker works. It doesn't. Hold on a second. Okay. So just kind of a quick reminder of our center, the Center for Health and Humanitarian Systems. From a vision and from a mission perspective, I want to highlight on the vision that our vision is to develop tools and collaborations in order to transform the decision making, because we want to improve the healthcare operations, healthcare delivery and humanitarian systems operations. We accomplish this through multiple pillars: education, outreach, projects, and innovative research. So when I was thinking about how to do the introduction, before I do that, let me say welcome also the rest of the directors. So let me introduce you've met Pinar. My co-research directors are Dr. Goldsman and Dr. Iyer. I don't know if they're here now, but I know that a lot of their students have poster presentations as well. Okay. And I want to thank all the support staff, Jocelyn, Andy, Sorbinita, Taylor, and Abigail. Thank you all for your support for putting this event together. It's not an easy thing. It's really logistically very challenging. And we appreciate all of their work for putting this together. So let's actually clap for them, because it was. Okay, so when I was thinking about this talk, right, and kind of just the introductory, I was curious to know what is the history of healthcare in the U.S., right? Where it's every day we hear about healthcare. You open the TV and there's something about healthcare. You open the radio, you listen to a podcast. There's always something about healthcare. So I wanted to kind of look at, okay, when did it start? How did it evolve? And I'm not gonna walk you through every step here. It starts from the late 1800s, where it started for the manufacturing workers, where companies tried to protect some of their workforce against sickness. There was no structure. It was a trial and error type of system. And then it evolves, the American Medical Association, it grew tremendously during this decade. There was organized medicine started and hospitals. In 1910s, the American Association of Labor Legislation drafted insurance legislation. And as you can see, as we walk through this, there was a few themes that emerge out of this. One of them is that repeatedly there was an attempt to have government-sponsored healthcare coverage that repeatedly failed. in the US. And there were some incremental kind of changes to the healthcare coverage system over the years, over different administrations. And that was kind of where US and the Europe started to kind of separate in their healthcare coverage journey. Another theme that one would see is a lot of the healthcare initiatives were quite reactionary, right? So the post World War II, employers were not allowed to kind of offer raises to to kind of attract more workforce. So the one way that they were able to kind of get more people is to offer them some healthcare coverage, right? So kind of it was always kind of it's evolving little by little in order to deal with the current problems in the decade. Um, in the 1960s, that's when the healthcare expenditures started to get tracked. And in the US, they were 5% of the GDP. And over the years, it started to grow little by little from 8.9, 12.1 in the 90s, 13.3 in the 2000s, and now it's at 17.9. So this is the health expenditures as percent of the GDP. Okay, so I'm sure everybody has kind of heard or seen something like this, which is if we would expect wealthier countries to have a much higher per person expenditure on healthcare than non-wealthy countries. But even if we kind of zoom in only on the developed countries, we know that the United States health spending per person versus the GDP is kind of an outlier compared to the other developed countries. In fact, so anybody can guess who this is? Which country is this one? Any guesses? It's a tiny, 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 tiny country in Europe. Luxembourg. This is Luxembourg. And this is Switzerland. Yeah. Okay. And then over the years, as we can see, there is a specific decade where the rate at which the US expenditures started to grow at a faster rate than comparable countries. Right? So in the 1980s is when the United States GDP, NHE percent of the GDP started to grow at a higher rate, and kind of the difference started to diverge. Another interesting thing is when we look at the public versus private spending across these countries, we see that United States is kind of in line with other countries when it comes to public spending. The difference is really in the private spending on healthcare. Right? So while these countries kind of they average about 2 to 3%, the U.S. is at a much higher. However, right, well, let's say a couple of more interesting statistics. So I was looking kind of, let's dig deeper into these costs. And I found those statistics to be interesting is most of a big chunk of the cost comes from administrative cost in the healthcare system, right? So huge cost goes to administration. Um, Another interesting statistic that's related to kind of the field that we work in, which is systems engineering, is that 50% of all chronic diseases are linked to preventable problems. And then the last one that I found also interesting is missed appointments, right? How much they cost the US healthcare system every year. So $150 billion per year are the costs of missed appointments, just people not showing up to an appointment. And this one resonates with me as someone who does a lot of work with the capstone senior design projects. Just about every healthcare clinic project, there is something about no-shows and the no-show rate and how different clinics have to deal with that by, buffering, by double booking, triple booking appointments, just to kind of hedge against that uncertainty. Now let's look at some good news for the US though, right? Yes, we're the highest in cost, but in terms of innovation, right, we come relatively in the top list, right? And we've actually climbed up a few spots from 2018 to 2019. Right? And this innovation index is, if you're curious about it, it takes many metrics and it combines them both on the input to the innovation, the infrastructure, the market, the infrastructure of the system, and on the output, how much technological advances were generated by that country. And when they put that together and they do the different weights, the United States comes third in the world. Another thing that was interesting in that report, they lay out a lot of promising fields for medical innovation. And one of the things that I'm interested in, or we're interested in, is the organizational and process innovation. And this is small font. It's not meant to be read, even though if you read it, that's quite impressive. The few things that I'd like to highlight are, things related to drone delivery of medications, telemedicine, virtual medicine, and artificial intelligence. And these types of terms, they resonate with us people in the logistics field, whether you're working with healthcare or just regular general supply chains. Um, these are common technologies now, right, in distribution centers and supply chain systems. So it's going to be very interesting to see how some of the research that's already been established in other supply chains, retail and commercial supply chains, how that can be translated into the healthcare systems when it comes to drone delivery or artificial intelligence and machine learning and data mining. Okay. So now I want to that was a good segue into talking about our systems engineering approach to looking at these extremely complex systems. Right? So when we talk about healthcare systems, the healthcare system is quite complex. Why are they complex? Right? There's multiple stakeholders. There's multiple interdependent subsystems, right? You cannot design one subsystem on its own. And we all know what happens if we try to optimize one aspect of that subsystem and there's an unintended consequence to another subsystem. There are, of course, physical spaces and limited resources and multiple organizations. There's government, there's people, there's insurance. And of course, these resources are shared, right? So you have a lot of these limited resources that are also shared across multiple subsystems. That makes these systems quite complex. Another aspect is the dueling objectives or conflicting objectives. So we have, if you try to minimize the cost, it's quite risky because then you're looking at sacrificing the service or the patient care. Right? So where is that balance between the two? And one of the things, as I was reading on the differences between the US and the other developed countries, is the reason why, one of the high level reasons of why the costs are so high for the US are two things. First, people come visit the high utilization of the resources. So US patients visit doctors or seek medical help more often than others nations per person. And of course, the cost per service is much higher. And one of the things that got highlighted from multiple resources is the idea that the defensive medicine that we have in the US, where you will always get the test that you think you should get, right? If you tell the doctor I need this particular test, most likely you would get it. While this is not usually the case in many of the other countries around the world, where there is more kind of not every test is available for every patient. Let's just say that. And then the other aspect of these healthcare systems is, of course, the data complexity and the uncertainty with the data and all of the gaps that we have in this data. So all of these lead into having these healthcare systems being extremely complex and the need for systems engineering type approach to design or to operate these systems. In fact, the White House PCAST report, and that's the President Council of Advisors on Science and Technology, they prepared a report in which they outlined some of these. And here are some kind of selected quotes from that report. highlighting the importance of systems engineering in order to address some of the challenges in the healthcare delivery systems, but also how systems engineering concepts should be embedded in education and training for people involved in healthcare. So what we believe is that, if you look at the different subsystems and you take them apart, they are fragmented. Right? And then through systems engineering, you can have a more coordinated and integrated health delivery system. And we have many, many tools that can be applied from systems engineering. You sometimes traditionally they were used for designing airplanes, and now they're more towards designing supply chains and distribution centers. But many of those tools are applicable to the healthcare system. And I am personally always looking for kind of seeing how we can make those tools even more. They consider more the practical aspects of a healthcare delivery system, because in a healthcare delivery, in a manufacturing flow line, there is a car that's going through this line, while in this case you have patients, and patients' behavior is unpredictable, but also the person who's working on that patient is also a human, right? So kind of all this human working on a human makes these systems even much more challenging than a traditional flow system. So I'm going to end with a challenge to you. I hope that you would benefit tremendously from this forum, but really to have some concrete output. What we would like that for everyone to answer, to kind of think about these questions. What knowledge can I take away for myself, for my colleagues, for my organizations, and the constituents we serve? What action can I take? And what action can I motivate others to take? Right? So this is your homework, right, for this forum. And hopefully by the end of this, you would have an answer for each one of them. Thank you. Yes, somebody. So now we're going to move on to the rapid fire presenters. We'll start with Dr. Nisha Bochwe, who is an associate professor of city and regional planning at Georgia Tech. And I also want to recognize Dr. Yajul May, who is an ISYE colleague, and Dr. Leanne West, and Dr. Yao Shea. I'm going to switch to your thing. Here's the clicker.
Thank you. Good afternoon, everyone. Good to see you. This is certainly a very warmed up crowd. So I'm going to get started, and the instructions were 3 to 5, so I interpreted that as 6 or 7. So bear with me. So I'm a city planner, and when I think about what the main contributions are to health, I think about this iceberg. It's interesting that it's freezing today and we're using an iceberg. We start at the bottom of the iceberg, where we have the social determinants of health, and so that's really based around where we live, work, and play, where we're born, the systematic structure of society. So think about this first column here to the right. That shows public transit that's moving along quite well and efficiently versus what we have in Atlanta next to that. The system itself leads to certain behaviors. Those behaviors lead, as you can see here, indicated by people engaging with one another, walking, being active, physical activity, human connection versus lack thereof, and a fair amount of stress. And perhaps many of us have experienced being in that kind of traffic here in the city. And then finally, the events. The events are at the top of the pyramid, and often these events are the things that we focus so incredibly on. It's the heart attack, it's the back pain, it's the headache, it's the broken leg from being in a car accident, or it's the joy and relationship that we have when we're connecting with other people and we're in communities where we really can thrive. And so it's in this framework that I think about what the true source of health is. And so the World Health Organization indicates that health status is determined The majority comes from the social conditions and behavior, so 55% and 30%. And healthcare here from the WHO is noted to contribute 10%. And this is not to say that healthcare is not an important component of seeing a healthy population, but I see that this is one piece, and we have totally ignored, in many respects, when we think about health and healing, the bottom of the pyramid and the behaviors that lead to these events and these outcomes. And then when we think about the health impact pyramid, this was authored a couple years ago by Dr. Frieden at the CDC. The bottom of the pyramid indicates the socioeconomic factors and the context in which the individual's default decisions can be healthy. It's at the bottom of the pyramid where these interventions can have a population level impact. But when you have a population level impact where you're changing the socioeconomic factors, how much are people being paid? Are they living in safe and appropriate housing? Do they have access to good and quality education? Can they get good jobs later so they can pay for the resources that they need to thrive in society? Do they have solid connected sidewalks so they can walk and get to places safely? That costs a lot of money. At the top of the pyramid are individual and group level interventions that don't cost as much. And so if we're changing the context, if we're dealing with socioeconomic factors, we really have to make a commitment to resources. And so in just the few slides I have left, I'm just going to give you an overview of the kind of work that I've been doing around health, equity, and engagement. And so this is a project that I started a couple years ago. It's called Measuring the Dream. And the primary question here is, since Dr. King's assassination, how far have we come in realizing his dream? How far have we come in realizing his dream? And so we developed a resource that essentially quantifies from 1954 to 2014 different components that we find in the I Have a Dream speech. And you can see here with regards to health, we start at 0.73 and we end at 0.91, where equality, as we measure it, is 1. And you may be thinking, that's great, we've made great strides. But the strides that we've made here as it relates to getting to 0.91 is because there's been a significant increase in mortality of white males between 30 and 45 because of the opioid epidemic. So we don't want to see improvement in this index because one group is doing poorly. We want to see improvement because all groups are improving overall. I've also done work on dashboards, as you saw in the circles. And so the first on the left is the Neighborhood Quality of Life and Health Dashboard, where we actually combine quality of life or built environment metrics with health data. And this is organized based on the Neighborhood Planning Unit system, which is the decision-making system here in the city of Atlanta. So communities can truly engage in what's happening around health and design and the structure of their communities. Then we moved on with some CDC funding to build the Fulton County Health, Environment, and Livability Platform. And now we're working on the House ATL Data Collective. And this is a database in collaboration with folks in the College of Computing to look at affordable housing in the city of Atlanta. A current project that I've been working on is the Youth Engagement and Action for Health project. This is engaging with kids. So we want to understand how training kids to be advocates in their communities leads to improved physical activity outcomes, nutrition outcomes, individual agency and well-being in those kids. So we've worked with kids all over the U.S., about 400 kids in Boys and Girls Clubs, after-school programs, and so on. And you can see pictures from Hawaii, which was perhaps the best trip, to here in Georgia and Virginia. We created a fantastic curriculum, and we've been sharing that with folks across the country. We have a paper that just came out where we are examining the intermediate steps in what we refer to as the ladder of citizen participation to understand how kids can truly partner with adults to have an impact on their built environment. And this ladder kind of shorthand moves from the bottom where communities are receiving information to planning processes, community processes, health processes. They are giving information, so their feedback where there may be consulted or they're on some sort of board to actually sharing or partnering with the information and the decision making and having power in what happens. And that's where you see true power. When we think about kids in this process, the Youth Engagement and Action for Health program has kids engaging um, in understanding how to assess the environments in which they live, whether it's their school environment, their nearby park, their home environment or neighborhood. And then they present to their adult leader who's running their club, we want to work on water fountains, or we want to work on improving our park. And based on those presentations, they pitch to a decision maker based on evidence, and they follow that through to some decision. And so with the water fountain example, that was our kids in South Florida. They were able to get a new protocol established to have the water fountains cleaned on a regular basis. And you may think that's not a big deal. But when you're 12 years old and you're in South Florida and it's blazing hot and the water fountain is nasty, having a clean water fountain is a big deal. And then with regards to the park cleanup, that was in Hawaii, Lihue, the Boys and Girls Club there, and they presented to their county council and they got $80,000 to improve their park. And so these are place-based, changing the context of the environment. So the healthy choice is the easy choice. It's the default choice. It's the attractive choice. I'll just leave you with two final slides. I think two final slides. This is some work that has been done in collaboration with my colleague Ted Russell in environmental engineering. Our student Abby Lowell, I don't know if Abby's here today, and some colleagues in Minnesota took a look at demographic inequalities in health and air exposure in Metro Atlanta. What you think is the case is truly the case. You can see the black lines show kind of a clear demarcation in different health outcomes. So the darker the color, the worse the health outcome. The image to the right shows red, majority black neighborhoods, blue, majority white neighborhoods. And so you can see that there truly is a disparity when it comes to these health outcomes with regards to air quality. And then finally, we're doing some really cool stuff with Google Street View, where we're pulling images from Google Street View. We just finished a study in Atlanta. We are working on this one that compares Atlanta to San Francisco, where we code the images from Google Street View based on air, sky, road, and sidewalk. Based on our algorithm, we're able to determine how walkable, or code areas based on how walkable they are. And we compare that walkability index to the walk score, and we found that our measure truly is more representative to where people indicate they are walking relative to what walk score indicates is a walking environment. And so this is helpful in that we can direct resources to areas that need to improve their walkability, especially if we know that there are vulnerable populations in that community. And so I'll just end by kind of emphasizing that when we think about moving from sick care to health care, we want to consider a broader envelope or a broader umbrella of what the medium by which that is should be operated through. And so, yes, I believe very dearly that if you need to go see a doctor, go see a doctor, and you should be able to find that healthcare resource in your community, and it should be accessible. But there are preventative things we can do, kind of the root and stems idea. There are preventative things we can do so we don't have the prevalence of heart disease and diabetes and all of the things that we know we have in this country that do not show up in other places. Thank you. Thank you.
Okay, let's see who is next. Okay. So Leanne, sorry, just a little bit confusing about our order. So Leanne, so next we have Dr. Leanne West from GTRI.
Hi, everyone. Thanks for having me here this afternoon. What I want to talk about is some of the things we're doing in pediatrics around Georgia Tech. And I just did something bad. Okay. Sorry about that. So you may or may not know that Georgia Tech has something called the Pediatric Technology Center. It was stood up in 2012 in conjunction with Children's Healthcare of Atlanta. And it started with a $10 million gift. And so we were able to fund a lot of research in that relationship. And we do it in research areas all across campus. So everything from 3D printing and medical devices to nanotechnology and special coatings for tubings, regenerative medicine, diagnostics and imaging, maybe even applying machine learning to those so you can see how images have changed over time. Mobile health is huge, as you can imagine. Health data analytics, we did a lot of that work here in ISYE, drug delivery methods, and we also have programs for students. So there's a lot of opportunities to work with Children's Healthcare of Atlanta and other pediatric hospitals that we work with here at Georgia Tech. One thing we do, though, is we only work on clinician-driven problems, and that's really important because academia in general tends to like to study something and then figure out what could you do with it after you understand it. What we're doing is we're saying we have a problem in the healthcare, the clinical setting, and we want to fix it. So what can your engineers come up with to do that? We have several different funding mechanisms to make those ideas come to reality. So everything from an innovator program called Quick Wins. The idea there is very much applied research. So what can you do in a matter of like maybe 12 months to 2 years? What can you bring to the clinic that could help them already start solving their problems? We've done enabling research, so more of the basic kind of research, maybe looking at virus-like particles or whatever it might be. Child impact grants are also along those lines, kind of the bigger grants with a longer period of looking at. And now we also have an innovation fund. So the Emily Foundation decided to give Georgia Tech and Children's a $5 million endowment. And now we get to fund a couple of projects every year through that innovation fund. And again, we work in all areas of campus, so it doesn't matter. We've done things in policy and modeling and whatever else it might be. We work all across campus, so anybody could be included. It doesn't mean that you have to have even a health background at all. A lot of times it's really just the engineering or science skill set that we're looking for, and maybe we're applying it to something different than what you typically apply it to. Again, we have lots of students, opportunities for students as well. There's one program in particular called the Petite Scholars Program. It's run out of IBB, and the idea is to bring an undergraduate in with a faculty member and a postdoc or graduate student to work on a project during the course of a calendar year, and the goal is then to be able to have that student present a paper to really help further whatever research area they're working in. Oh, and I will say with that, students from all over the city can participate. So you could be at Morehouse or Spelman or Agnes Scott or Emory. It doesn't matter what school in the local area that you are, Georgia State, Kennesaw. We also have another resource on campus that you may or may not know about. It's called the Global Center for Medical Innovation. And the idea there is to help small companies with their startup. They do small batch manufacturing. They can help you with FDA regulations and all sorts of things like that. So they're a fabulous resource. You can also do animal trials there, cadaver studies. So it's another great thing that if you're interested in, please feel free to reach out after this talk. Like I said, this started with Children's Healthcare of Atlanta, but we've been working with a lot of other hospitals as well. One is Children's Mercy in Kansas City. Shriners Hospitals is a new one, and they're interesting because they're actually 20 hospitals around the U.S. and one in Canada and one in Mexico. And so they're going to be a really great partner. They do a lot of mobility studies and understanding how a person moves. Children's National in D.C., they're great too, and we just had them to campus. And also Cincinnati Children's is going to be a new one that we're going to start in the new year. One thing I wanted to convey is that as a part of this, just like we're working with all sorts of other children's hospitals, in pediatrics, the resources are really small, and so you have to use them wisely. And one of the things that happens in pediatric research that is not as common in other types of research is it's very open. Everybody wants to do what's right for the kids. And so if it means that the two of us work together and I wouldn't normally work with you, that's okay, because it's all about making a kid healthy. And so there's several organizations that we participate in. One is the International Society for Pediatric Innovation. This started about 4 years ago. It is all about what is healthcare going to look like in the next 40 or 50 years. And the vice president of the organization is Sherry Ferrugia. She is a faculty member here on campus. And we've both been involved in that organization since the beginning. I sit on their board. And then we also work with the International Children's Advisory Network. So I'm the president of this organization, and Sherry sits on this board. So it's really great to have both of us here kind of working towards the same goals and kind of bringing these organizations together that in the very beginning they didn't know each other existed. ICANN has also been around for about 5 years. And what it's all about is giving the pediatric patient voice in healthcare. And so what Nisha was just talking about, where kids would go and talk and get money for a park, this is the same kind of thing. So today, for example, we have 7 kids presenting at the FDA, and I just received a text with pictures of them talking on stage. But it's all about giving them opportunities to tell their stories. They are the experts, and so I'm going to go off a teeny bit off topic here for just a second because I'm presenting a little bit for somebody else who couldn't be here today because she got sick. But what's really important here is it's really important to include kids when you're looking at healthcare. It's really important to understand their perspective. They are the experts at living with their condition. They are the experts at knowing what it's like day to day and what issues that they have. And so even a doctor who's been trained and maybe is an expert in that condition from a medical standpoint, they're not living with it every day. It's not their life every day. And so it's just really great and important to include kids in research. And one of the things that I think is really interesting, and I know this is a story that Megan would have told if she didn't get sick, is she's working on a project that we have with Children's Healthcare of Atlanta. It's called Cancer Care for Kids by Kids. And the whole idea is to help kids kind of more seamlessly get through doctor's appointments when they have to go in for chemotherapy or whatever it is. And these are long days for them, and they're not very fun for these kids. And so it really started out as what could we do to make this a little bit easier on the kids? You know, maybe less time in a certain waiting room, maybe giving them virtual reality, video games, all the things that you might kind of think of in your head. But when they asked one of the girls, they said, you know, what would make this a better experience for you? And she said all she wanted was a private bathroom that she could throw up in and not have everybody around her. And you're like, okay, it's such a powerful thing to go from, you think you're going to get bright colors and games and things, and it really wasn't about that at all. So it's really important to talk to them. I give you this. These are all the community partners for the International Children's Advisory Network that I'm the president of. But what this shows you is that we really work all across the industry in pediatric healthcare. We work with the FDA. We work with NORD, all sorts of international groups as well. And so we really are involved all around the world in pediatric healthcare. And again, we think that's good because you get everybody working together for the same goal, and that really makes a difference. So here I'm going to talk just super briefly about a couple of projects that we have, just so you can kind of get a high-level idea of some of the things that we've done. We have worked in the policy area, so looking at what does it cost the system if you diagnose a child with autism at 5 years old versus 18 months? Can we convince lawmakers that you're going to save so much money over the life of that child that it is well worth it to require a testing at 18 months as opposed to when most kids figure it out when they go off to school? Pediatric kids in the state of Georgia. So how does it work for you if you are somebody with asthma and you don't live near a center who specializes in asthma? What does that look like, and how bad is that? And so they figured out that the outcomes for these kids who are 20 miles or more away from a specialist in asthma care, that their outcomes are much worse. And so what this was used for is to help Children's Healthcare of Atlanta look at the state of Georgia and figure out where they wanted to place the next urgent cares or specialist in the state to help combat this problem. This is a designing cancer care for kids by kids. It started out as something on paper where the kids feel scared, where they want to have different things happen. And now it's turned into an iPad app that is being used at the Aflac Cancer Center. And again, a lot of this is about, how can we ease the anxiety that some of these kids feel throughout the process? Where does it really kick in, and where can we help improve that? And by the way, private bathrooms are being installed in the new children's hospital when they build it in this section so that these kids can have that. Data analytics. Let's see, what is this one? Oh, yeah, this is pretty cool. So one of the things that they're working on is for kids with with autism, severe behavior problems. They have a lot of repetitive motions, and they can be very violent, but a lot of the times it's repeatable. You can see the motion that they have. And so what they're doing is they're going to use sensors worn on the children so that they can pick up whether or not the treatment is working at the home when they go home after training at the facility. And so it's a way to monitor and just kind of get eyes on an understanding of truly what is it like when the child goes home versus when they're there. MRI system, again, you think bright colors, maybe fish on the wall or whatever, but they figured out that if the kids could control what light color it is, that's what made them happy, because it was something that they had control over. And I know that that's a big thing when someone who's sick, especially with something chronic, you really don't have a whole lot of control over a lot of things in your life. So any little bit that you can give them tends to help. This is another one, and I think this is my last one. This is an app that we made for the Marcus Autism Center, and I'm sorry I didn't realize I had all Autism Center projects here, but it's an app we built for them. A guy there works on something called the feeding program, so kids who do not eat. It's not that they have eating disorders, it's that they have feeding disorders. They're not going to take food by mouth for a variety of reasons. Usually it relates to some sort of bad healthcare experience when they're an infant. And there's a program that somebody at Marcus figured out how to do this. It's a 6-week program. It's very time intensive, multiple visits per week to the specialist here in Atlanta. And this is for kids all over the country. And it's around $60,000 a child. Well, what we did is we took this protocol out of his head and off of this stack of papers that literally had food splattered all over it, and we put it into an app. So very obvious, right? Like, that's super easy. It makes a huge difference. They can now analyze the data right away. But the other thing that it does is it allows other clinicians to use the protocol to help get these kids off the wait list faster. He thinks about 90% of kids can use this app to start eating again. And then he can really focus on the most severe 10% that really need his expertise. But then the other thing that happened through this is he realized that he could give this app to parents after he diagnosed them and explain to them what they need to do, and they could take this home, and now they could do this at home, so they don't have to travel to Atlanta anymore. Parents not taking off work, kids not getting out of school. Overall, and plus about half these kids have autism, and so taking them out of their routine is not necessarily fabulous for these kids. So we really changed the way that he thought about giving care. He had never considered this possible, and we made it possible really just by creating a digital version of what he was already doing. Symptom management, this is one more. This is an app for kids with colorectal issues. And, oh no, this one isn't. This one is for nephrotic syndrome, just measuring the color off of a color stick when they urinate so they can take better records of what their protein levels looked like in the urine. We have another one for colorectal management, just to help kids kind of, if they take better care of themselves and they're more aware of what's going on, then they're going to have less accidents. This might be my last one. So this is CLABSI. CLABSI is central line infection, terrible for hospitals. It's what hospitals kind of get sued for all the time when infections happen in the hospital because of the way you connect all the IV lines. And they, those little towelettes that you might clean your hands with at a, that are in a little square package. That's what they currently use at the hospital on joints of these things that actually have, it's like a cup with something sticking out of it, and that's what this other tube fits into. Well, you can imagine that the towel doesn't reach down in there where actually all of the problem is. And so we have a guy in material science on campus, and he came up with essentially a sugar cube of material that's soaked in alcohol. And you can see that it's just ridiculous how much better it is than even what's the standard in healthcare right now. last one maybe. Sorry. So this is IV infiltration, also a bad problem for the hospital. Lots of multi-million dollar lawsuits if this happens and it gets bad, because if you have an IV and you're getting a drug, and let's say that vein breaks, and so that liquid, or it's missed completely, the liquid goes into your skin area, you can see the horrible things that it causes. It can completely eat away at all the muscle, bone, nerve, everything, and cause these children permanent damage. It happens in adults too. So we have a group in mechanical engineering who's making a system that's going to go in the dressing around the IV site, to using flexible electronics to detect when this happens. They said if we could do this within 30 minutes, it would be wonderful, and we think we're going to do it in about 2. So we're super excited about that one, and that's it. So I don't know if anyone has any questions, but feel free to ask them, and also reach out anytime. I'm happy to talk about what we have going on, or ideas that you have, or whatever it might be. Yeah. Yes. Thank you. Yeah. Yeah. So I mean, again, another one of the things about us is we do work on real world problems. So we like to have real world solutions that can actually be used. And I think that is a little bit different, but truly everybody that we work with really appreciates that. That, you know, people have been working on things that now they have a real problem that they could apply it to. So it's good. Thanks.
Let's see. I think it's going to be. Oh, yes, it is Yajun. So for a very different talk now, I want to welcome my colleague, Dr. Yajun May, and he's going to talk about biostatistical consulting and his research interests. Here's the clicker.
Yeah,
I'll give you the 5-minute warning.
Okay. Yeah, thank you. Yeah, thanks, Bettina and Dima invited me to come here. And yeah, the previous talk is very impressive, and now my talk is talk about a different aspect. And so I'm a statistician, and here I want to emphasize that just want to introduce some kind of like the statistics report or opportunity at Georgia Tech. And so this semester, say for example, I will normally hold the free weekly biostatistics consulting sessions during 10:30 to the 11:30 on Mondays in IBB 1317, and so this kind of like the kind of biostatistics consulting sessions initialized by Professor Brian Fadovis and our colleagues, and to support the junior researchers. Okay, to the junior researchers, and so the originally, so the for those students or postdocs, and will, if you have any statistical questions, and welcome to stop by and my sessions, and also for faculty, feel free send me emails, and also welcome stop by to the chat. So in the past, what we have done in that and biostatistics consulting sessions, or in general support would be kind of answer some questions ranging from the design experiments or sample size calculations or power analysis, longitudinal data analysis, time series, and or some like the modern data mining or machine learning method, and so on. And in the past, we also work on some students on either the kind of like papers and some kind of get review comments, and we say how to address it, or some like faculty or the kind of like the grant proposal, they need some supporting letter and from the statistical support, and we will be also very happy to provide it and through this board. And sometimes, and so I can give you one concrete example. There's one postdoc and at Georgia Tech and Emory, BME, and get an NIH grant proposal and get the kind of ask the revisions and the review comments, say, okay, how do you justify the sample size and in the proposal, and the researchers say, oh, it's because that's how much money I have it to do it, but in the proposal you cannot write that way. So we recommend them, say you need doing certain like a power analysis and sample size calculations. So that's the general kind of a framework and support we will provide it and in these cases. And so this support is supported by the so-called the biostatistic, epidemiology, and research design, and we call it the BIRD of the Georgia CTSA. I'm not sure in this room people are familiar with the Georgia CTSA or not. Georgia CTSA is kind of like is a big NIH grant and from the mainly from the Emory and Georgia Tech and the UGA and Morehouse and for part of my job and initially is the Professor Brian Fadovich is the co-director for the BIRD and at Georgia Tech and Brian now work on the NSF program manager, so I step on big shoes and try to fill in his position. And maybe next year Brian will come back and he and I maybe share the duty of this board and support. And so this board program and have kind of like two kind of leaders and. So we are the co-director for the Georgia Tech, and on one side, the Professor Andrew Garcia from the Georgia Tech is the director for the Georgia CTSA at the Georgia Tech, and Professor John Hanfield from Emory is the director, the overall director at the BIRD, and because the Emory biostatistics is bigger and than us. So for those of you researchers here in this room, and especially to the junior research and particular graduate students or postdoc, if you have any statistic questions, and feel free and let us know. We will be very happy work with you. And I also want to briefly mention my besides this kind of consulting type and the service we provided or I have provided in the last several years. And I also want to my own personal research and focus on and high level on a particular one project. And in general, my research work on the thing related to sequential analysis and or quick detections. And for the methodology research in statistics, and I receive an SF career award in that directions, and also and I also work on some like a biostatistic or the health related research and by using my postdoc experience in the Fred Hutchinson Cancer Research Center in Seattle. And over there, I learned more like the infection disease and the HIV dynamics. And recently, I also work on the gonorrhea data, and which is we will talk about next. And we also work on some engineering applications, and especially the quality controls and the sensor network or information theories. And I try to keep my slides kind of like simple and so probably this should be about my last slides. And so I just work on the one specific examples I have and to indicate what kind of research we have, and both the collaborative research and the methodology research. And this one is to talk about the multi-drug resistant gonorrhea disease. Gonorrhea is the second most commonly reported notified disease in the United States, and the increased rate over the past several years. And in particular, you can see this and the graph here. Somehow they shift a little bit. They shift a little bit. So you can see they depend on different group and the some group populations and the disease rate is more stable, and there's another group and there's other groups. You can see the disease rate will increase dramatically and so on. So the CDC they had the 5 recommended treatment and options in the 2006, and but now these days has only one treatment left, and due to the multi-drug resistance. And the United States actually is a better shape than European. I think in the Germany, So now there's cases there's no treatment available, and so due to the drug resistance, and so in the CDC is kind of like they notify there's extensive data at the CDC, and in particular they have the so-called the National Notified Disease Surveillance System, and since the 1944. I also talked with the colleagues at the CDC, and they have say. And they have the public available data, weekly data at the CDC. However, they will not be able to get the individual personalized data due to the privacy. And so a lot of our research and we talk with the high level weekly data at the United States by getting the data from CDC website, and it's very kind of every data is over there. If you are interested, I can also show you how to get it. And also individual data, we try to have a collaborator in Seattle, and Dr. Karani, and from the Fred Huntington Cancer Research Center, and she is kind of like the medical doctors and provide support. And I just let you know a small part. So during this project, and the one thing when we talk with them, they kind of the CDC, there's certain guideline to say, and the protocol would be they conduct the drug resistant test to the first 25 men at each month at each of its clinics, and then using that data to make the inference about all the populations. And sometimes and I know the people here in the room will immediately see there's a sampling bias. Just because the men population is high risk, you cannot just sampling all your data, drug resistant data, to the men populations. So this kind of but I also talk with them, why are you doing this one? Any kind of particular reason? They say, because of the historical reason, there's no particular reason. It's just simple. It's the policy was established during the Second World War, and people just use it and forever, and for the laziness of the, or maybe for the convenience. And so this kind of project, and talk with them and invite us doing several projects, ongoing projects. And one is that the Yujie Zhao is our PhD students and work on to look at fitting the data, and to look at and find the trend of this spatial temporal, and of course the 50 the United States or different states using the tensor decompositions. We write the methodology paper and also apply the paper, and we also work on other students and work on the multi-unbounded problems, and say based on this sampling how to efficiently and sampling so that you can test which group of populations the disease rate will increasing or the drug resistance rate will increasing. So I will stop here and just let you know. So we have the go back to this. We will be able to doing the statistical consulting or the methodology development, and hopefully you will use the resource at the Georgia Tech or the Georgia CTSA. And if you can't, I think that's it. Thank you.
I have a question. So these consulting classes, are they open only to students, or students, faculty, Emory, Piedmont, or just
Yeah, you
just
can.
anybody
Anybody can use it.
Okay.
Yeah, but we only for the other ones we will put a cap, maybe say a couple of hours for the senior person like you, Pina.
Oh, thank you. All right. Well, now, last but not least, is Dr. Yao Shi, who's also a colleague in ICE. You're going to use this one? Okay. Let's see. Here we go. Do you want this one, or you're okay? There we go.
All right. Good afternoon, everyone. My name is Yao Xie, and I am an associate professor at School of ISPIE here at Georgia Tech. So my main research area is in statistics and machine learning. So today I would like to share with you one particular project I've done in this domain, and this is a collaboration with our students, my student Shihe, who's close to graduation, and Lian Xie, and our colleague Joe Soko, and Pinar, of course. And so in this project, we want to study. This is more focused on methodology and developing decision analysis tools for pediatric organ transplants. Okay, so here's the description of the problem. So the motivation is if you look at the literature in survival analysis for organ transplant, and so a lot of this existing model literature is actually built based on adult data, adult study. And so, but if you look at the characteristics of adults versus pediatric patients in organ transplant, is very different. So, fortunately, if you look at the survival rates, it seems like pediatric patients has much longer survival, much better survival to organ transplant. And if you look further, you actually find out actually the decision variables which decide what is the best match for organ transplant and recipients is different. It's going to be different. So that makes a lot of sense because kids, the children are different in size and their body hasn't been fully developed, so the decision variables should be different. So the goal in this project is we want to look at the data and develop new survival analysis models to help doctors to matching recipients with organ donors to help these kids need organ transplants. And why do we need to decide this model is very important because these are the tools that doctors, when they decide, they have to decide very quickly. And typically an organ, once it becomes available, it's only available for probably 48 hours. That's what we learned from our collaborator, by the way. I should mention this is a collaboration with CDC. Data is from them. So our collaborator, Brian, told us, typically it's only available 48 hours. So doctor, given the limited amount of time, had to make a quick decision using these tools combined with their knowledge. So having a precise survival prediction model and saying based on this characteristic, this matching of the recipients and donor, how likely is it going to be successful? How long is this going to be successful? And so it's very important to have a very precise model. And another aspect is typically it's impossible to find a perfect match between the organ and recipients because organ is a very scarce resource. So if there's no perfect match, then and maybe you can tolerate a little bit of mismatch in some characteristic that's not super important, but this can provide the organ transplant much sooner for the kids, and that's also very important. So the goal of the research is to build a model and also identify which factors are most important in making a decision. Okay, so here is summarizing what I just said. What is our goal? Is we want to develop these survival analysis model based on data to predict how successful, how long the case is going to survive after organ transplant. So if I give you the characteristic of this patient and all the characteristic of the donor, and by matching these two characteristics, how likely is it going to be successful? How many years the case is going to survive after this operation? And identify the most important factors. So not only you have a model, but it's interpretable. Then doctor can use this knowledge to make their own judgment as well. And so this is our contribution. So as you can see, it's focusing one particular aspect. I think this is probably reflecting. I think it coincides with the earlier presentation by Dr. Lian pretty nicely about pediatric research. This is one particular aspect of pediatric research. So we want to develop this new methods and new model to help making decisions. And here is a list of summary how do we approach this problem. So the data source we have is from this UNOS, United Network for Organ Sharing. And so it's a very comprehensive data set, contains lots of data actually ranging from 1987 to 2014. And if we look into the data, there are 19,000 cases of different cases, and in particular, we look at kidney transplant. In this data set, actually, it contains, besides kidney, but also other organ transplant. Here, as first step, we look at one particular organ transplant. And so, so the way we did this is we built the survival analysis model, and we used two approaches. One is the classical statistical approach, based on the so-called Cox model, Cox proportional hazards model, and the other is more a machine learning model. Since machine learning is very popular now, and people believe this is going to be sometimes more robust and capture nonlinearity in the data, so we tried both approach and did comparison. And so, in terms of performance metric, we considered two commonly adopted metric, the C index and integrated Breyer score, in comparing these methods. And so, we want to build this model, compare between the statistical and machine learning approach, and also compare these new methods with the earlier developed method based on adult data only, and see did we really have improvement by building this model. And good news is, indeed, it's worthwhile to develop these models. And we also select the variables in identifying which factor is most important. So you see it's very interesting that indeed the factors for deciding for pediatric patients is going to be different from the adults. Okay, and so the data is going to be non-homogeneous because so how do you decide is a cutoff for kids? How young is a kid? Is it going to be 2-year-old, 3-year-old, maybe 7 years old? So how do we decide? So we decide to use change point detection, which is one of my research area, to decide the cutoff. And so the cutoff means that we should build a dedicated model for this particular age group. And maybe the cutoff also besides the age are some other variables. So how do we decide? Okay, so I'm just going to give you two slides peek into the methodology here. And so the first one is a group-based, graph-based variable selection. So this is basically coupled variable selection, meaning selecting the most important factors together with the survival analysis. And so this is our formulation. So at this part, actually, we also have the some statistical methodology innovation. Why do we consider graph? Regularizer or graph-based method is because we have 448, I think 400 some features, and these features includes the genetic features and the medical tests and gender and a lot of information, and these variables are typically correlated. This graph structure will help us to incorporate this correlation structure between the variables and also help us incorporate prior knowledge, medical knowledge into making the decision and choosing which factor is important. Okay, so this is one result we have from the variable selection. And so this is one of the plots, and this is comparison, basically the variable selection coming out of our statistical machine learning approaches and compared with the adult-based only model. So these are the variables selected from the adult model. So a couple of takeaways from this is actually identify indeed there are different factors. For example, we find out for pediatric patients, I think one thing so the donor age is very important. Okay, so I guess it makes sense because you have to consider the difference in the age of the kids versus who is donate this organ to the kids. And another thing important is the weight of the patient. So I think it also makes sense because the development stage of the kids depending on how heavy, how gross they are versus the actual age. So we find that to be important as well. And this is going to be the grouping part. So for example, we find out so how do we decide how to cut off to build different models? So we decide to build 3 models in the end. And the cutoff age are going to be recipient's age is 1.5, 1.5, and 1. So this basically means that kids below year 1.5-year-old is going to be one model, and then between 1.5 actually to 9-year-old is going to be another model. So it also makes sense because for babies and for slightly older kids, and you should probably have different models. And so this is the final slide I have is the comparison of this approach with existing approaches. Indeed, this new method, which is tailored to pediatric data and selecting variables according to pediatric characteristics, achieve much better prediction and survival rates compared to existing models. So this is the research stage so far, and we're hoping to actually making this model available to practitioners and doctors and patients when they make decisions about this. And we hope this can help kids, patients, and be more effective making their decisions. Thank you so much for your attention. Mm-hmm. Mm-hmm. Right. Right. That's yeah. So the that's the bottom line is because the bottom line is why do we need dedicated model? Is it because the characteristic of data and distribution of the data is different for very young kids versus older kids versus adults. But what is going to be the precise decision boundary? Is it going to be 1 year old, 2 year old? So how do you decide? So we use statistical method to decide these cutoffs. Thank you.